Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Then start the serious part of this question paper. So you had a question on familial gynecological malignancies. Can you guys name a couple of familial gynecological malignancies? Can you just name a few of them? How many of them do you know? And suppose this question is asked you without this reading this answer. How many can you write down without looking at the answer that I'm about to give you? Come on, guys. I need your responses. I need your responses to finally get on to understanding. This is called a snowballing effect. I'm trying to understand how much my students already know. According to that, I'm giving you the answer. And according to that, I'll go slow or fast in my approach to understand whether you are getting the basics of what you mean by familial gynecological malignancies. Okay, one is HOBC, absolutely. Hereditary ovarian breast carcinoma, absolutely right. BRCA syndrome, right. Then you have the Lynch syndrome, in which you have colorectal along with endometrial cancers, okay, and ovarian cancer, correct. You have HNPCC, Lynch, one of the same thing. Anything else? Anybody heard Cowden syndrome? Anybody? Anybody heard Cowden syndrome? Yeah, Peutz-Jeghers also I'll take up. All right. So basically, these are those malignancies in which you have more of hereditary aspects or hereditary nature. They finally lead to the complexities involved in the diagnosis and management. So they have a specific genetic syndrome. These are actually specific genetic syndromes that predispose the individual to various types of cancers. Okay, they're in your genes. So one is Lynch syndrome. I just told you one. Then you have HBOC, Cowden syndrome, which I just spoke with you about. Lee-Frobeny syndrome, okay, Peutz-Jeghers syndrome. I have discussed only these, okay. There could be many others, but I have discussed just these 5 of them, which are expected out of you. So, Lynch syndrome, hereditary non-polyposis colorectal syndrome, as the name suggests, it's an autosomal dominant variety. You have colorectal cancer, you have endometrial cancer, you have ovarian cancer. These 3 cancers are together. I'm currently dealing with a patient who is a patient of this Lynch syndrome. So her family has got a history of, all fathers, grandfathers having this colorectal cancer, and all the females having endometrial or ovarian cancer, which is very, very dangerous. So I have proposed her early marriage, early children, and early risk reducing surgery, which we're going to deal with right now. So the question was very specifically about describe these malignancies. So even if you write down 2-3 lines per malignancy, this would be sufficient for a 5-mark question, which I'm expecting it to be a 5-mark question. So you have, even if you write down 2-3 sentences, I've written more than a page. This is just to make you well versed with this concept. So the autosomal dominant condition, colorectal along with endometrial ovarian cancers, and you've got a lifetime risk of developing endometrial and ovarian cancer, approximately 30 to 70% endometrial cancers and 4 to 25% ovarian cancer. So mostly the females in their family have endometrial cancer. And Lynch syndrome is caused by mutations in DNA mismatch repair. I hope you already know that. MMR genes such as MLH1, MSH2, MSH6, PMS2, correct? And basically, you have the clinical criteria Amsterdam 2 and Bethesda guidelines. According to them, you do the diagnosis. Screening is that you have to have at least biannual colonoscopy, annual or biannual colonoscopy starting at the age of 20-25, and transvaginal ultrasound and endometrial biopsy starting from the age of 30-35. So I have been calling this entire family since years together, along with me for this transvaginal scans and endometrial biopsy, but they get lost to follow up in between. So it's very, very dangerous. Very, very dangerous. Someday they can just simply have endometrial carcinoma, and even worse if they have ovarian carcinoma. So very important. One of them is not unmarried up till now. Okay, so it's very, very difficult to handle these patients, specifically if they are not serious themselves. So how can you save them? Anyway, so, and plus you have that, maybe they've gone to another gynecologist. That kind of a thing. So I really wish them well. I hope they're really seeing another gynecologist, but I think that's very, very essential for them to keep getting these annual checkups and to go in for the risk reducing surgery, because once they do get ovarian carcinoma, it's the end of it all. You do know that even after the risk reducing surgery, the risk of ovarian carcinoma is not reduced by 100%. You do know that, right? Very important. Specifically, I'm saying about ovarian carcinoma, the most notorious of all carcinomas in females. Then you have hereditary breast ovarian cancer syndrome, BRCA1, BRCA2 genes, which you know very well about. BRCA1 mutation carries a risk of about 39 to 63% for ovarian cancer, and BRCA2 16 to 27% of risk. And BRCA1, BRCA2, again, these autosomal dominant genes involved, and you can go in for an annual MRI, annual mammography starting at 25 for breast carcinoma, and transvaginal ultrasound. See, it doesn't help. Nothing is a screening tool for ovarian carcinoma. It doesn't work. Doesn't work that way. Only one thing works, which is risk reducing surgery at the age of 30-35. I think I just spoke with you about this thing, right? Or is it going to come later on? It was there. Risk reducing surgery at around 30-35 years for the ovarian carcinoma, and around 35-40 years for the uterine carcinoma. All right. Then you have a Cowden syndrome, where you have the mutation of the PTEN gene. If you just write on this, they'll understand that you know. You have a high risk of breast, endometrial, and thyroid cancer because of Cowden syndrome. And it's PTEN is actually a tumor suppressor gene which gets mutated over here. Again, you can go in for an annual mammography for breast carcinoma starting at the stage of 30-35. Endometrial biopsy and transvaginal scanning at 30-35, but it's nothing works for ovarian carcinoma. Fortunately, here you have breast and endometrial and thyroid cancer, which are still manageable cancers. Leigh-Fromeny syndrome mutations in the TP53 gene, okay, leading to a wide spectrum of breast, sarcomas, and brain tumors. Again, Leigh-Fromeny is far more dangerous. Annual whole body MRI starting at age 20, and breast cancer screening as for high risk population. So we've been seeing up till now the breast carcinoma screening for the high-risk population starts at the age of 30-35, not at the usual stage of 40, which is usually starts for a low-risk population. But it's an annual screening anyways. Then you're coming on to the Peutz-Jeghers syndrome. So there is a mutation in the STK11 gene leading to the syndrome. You have mucocutaneous pigmentation of family history. You have you have cancers including breast, ovarian, and cervical over here. Now we have another cancer. We have a cervical cancer with Peutz-Jeghers syndrome. So basically, you can go in for pap screening. You can go for mammography starting at the age of 30, like for all high risk population. Now, how will you counsel a 32-year-old female with a history of ovarian cancer in mother and a CA breast in maternal grandmother? How will you counsel her? For what will you counsel her? For screening, for risk reducing surgeries, for responsible lifestyle? What and how will you counsel her? First of all, this is basically a hereditary breast ovarian cancer syndrome, okay? And BRCA1, BRCA2 being the tumor suppressor genes, they are the ones who got mutated over here. These genes, they're crucial for the repair, and over here you have an inherited defect in these two genes, BRCA1, BRCA2. Well, I don't think that any of these things is going to come in that, but this part might be important. So for individuals who have BRCA1 mutation, the lifetime risk of developing ovarian cancer is between 69 and 63. While for BRCA2, now this, guys, no matter how far-fetched it looks, guys, this part is important. When you're counseling a patient, many of my students are telling me, ma'am, counseling, but do we have to remember statistics? Yes. Answer is yes. Counseling means you have to tell them in statistics, what is your chance of developing this carcinoma? What is your chance of developing this carcinoma in 5 years? What's your chance of developing this carcinoma despite risk-reducing surgery? Or risk-reducing surgery at what preferable age to avoid development of this particular carcinoma? How much by percentage is this screening test going to help you? And if you do not get this thing, how much are you going to be affected by it? So as many percentages as you can throw when you're counseling a patient, that's going to fetch you marks. So yes, it's important. For individuals carrying the BRCA1 mutation, the lifetime risk of developing ovarian carcinoma is between 39 and 63, while for BRCA2 mutations between, maybe you can say 16 to 27 or 17 to 27, you can say that, just for the ease of remembering. Breast carcinoma is even more. Okay, so it is somewhere between 46 to 87 and 38 to 84 respectively. Mean age of diagnosis of ovarian cancer in BRCA1 carriers is approximately 45 to 51 years, and diagnosis in BRCA2 is 57 to 63. So you see how early we have to start with the screening. So basically, for BRCA mutation carriers, ovarian screening, cancer screening, including transvaginal ultrasound, every 3 to 6 months, starting at the age of 35. But guys, do you know, and MRI for breast cancer at 25 age is recommended. But these recommendations, they are not in sync with the RCOG, because RCOG tells you that there's nothing that can screen for ovarian carcinoma. So no ultrasound, no CA125 is going to help you in screening as a screening modality for an ovarian carcinoma. So best is risk reducing salpingo-oophorectomy is advised between the ages 35 and 40 for BRCA1 mutation carrier. Okay, this is what I was remembering. And 40 to 45 for BRCA2 mutation carriers. This is salpingo-oophorectomy for allaying the ovarian carcinoma. Prophylactic bilateral mastectomy may also be considered to lower the risk, but you can decide on. See, mammography is a good screening tool. CA125 in ovarian ultrasound is not. So if you want to avoid ovarian carcinoma, go for a risk-reducing surgery at the age of 35, 40 or 40, 45. And if you're undergoing, you want to reduce the risk of breast carcinoma, go for a regular mammogram. Genetic counseling and testing. Patients with a personal family history of breast ovarian carcinoma should be considered for genetic testing for BRCA mutations. And molecular testing specifically includes BRCA1, BRCA2 gene panels, but you can also have relevant other genes like RAD51C, 51D, and PRP1. Okay.